In the name of Allah, I start this video. I'm Isra, student of O State University International Medical Faculty, and I'm in 5th year. This is the self-individual work guided by our teacher S.L. Murzabek Kizi on cardiogenic shock. I'm thankful to her for giving me this opportunity. Today, I've got the topic cardiogenic shock. First, let us know the etiology of cardiogenic shock in VSD. Right ventricular dysfunction may be the major determinant of cardiogenic shock. In inferior left ventricular infarction, more right ventricular free wall was infarcted in those with shock than those without shock. In anterior LV infarction, more severe septal infarction present in those with shock compared with those without shock. Pathology. In pathology, from the starting of myocardial dysfunction, it has a certain process which leads to death. Clinical signs. ECG shows the pattern of AMI or acute coronary insufficiency. The SBP is less than 80 mmHg. Pulse rate is 100 per minute or faster. The urinary output is low, that is less than 30 ml or more. There are clinical signs of peripheral circulatory collapse. Some notes which should be known are develops in 10 to 20% of patients hospitalized with AMI. Mortality of such patients approximately 80% or higher. Very few patients develop shock immediately after AMI. About half of the patients develop shock within 24 hours. Starting law of heart. The ability of the heart to increase its output in response to an increase in venous return represents a positive feedback in which altered blood flow to the heart leads to a corresponding change in blood flow leaving the heart. Differential diagnosis of cardiogenic shock are massive pulmonary embolism, acute dissecting aneurysm of the aorta, acute cardiac tamponade, acute hemorrhage, cerebrovascular thrombosis, diabetic acidosis, acute pancreatitis, acute adrenal insufficiency. This is the schematic guide for diagnostics and therapeutic purposes. Emergency treatment. The emergency treatment here which can be given is in treating cardiogenic shock is to expand the circulating blood volume with IV fluids using the PWP or CVP as a basic guide. Here the initial treatment given are inserting a Foley's catheter into the urinary bladder to obtain accurate measurements of the urinary output. Then monitor the patient continuously. Then relieve pain, relieve agitation, take portable X-ray films of the chest. Definitive treatment here given are correction of hypovolemia, treatment of arrhythmias, treatment of hypertension, treatment of metabolic acidosis, treatment of electrolyte disturbances, mechanical circulatory assist. Correction of hypovolemia can be done by PWP less than 50 mmHg. PWP remains stable at 18 mmHg. Initial PWP is between 15 to 18 mmHg. PWP is 20 mmHg or higher. Rise in PWP to 16 mmHg or higher. PWP is low, approximately 5 mmHg. Pulmonary edema. Thank you.